Okay, hoping that fourth time's a charm. we are we are getting. I'm extremely excited about bringing Dr. Werner onto this account to talk about male infertility. We've had some technological difficulties. He's now going to try to join from his private account instead of from May's Men's Health, and we're going to hope that it works that way instead. And then we'll just have to see. Dr. Werner, I'm just going to start and start talking as if it's all happening. This is actually extremely humbling for me, I just have to say, because this is, thank God, this is my 16th live. And as I've said to many of you before, that I am meticulous about making sure, as sure as I can, to work out all the technological bugs beforehand, make sure everybody is comfortable with this technology, because there are many people who I do interview on here who have never done an Insta Live before. And so I always practice with everyone beforehand. We work out the questions and the order and so on and so forth. And this is actually extremely humbling for me, because in all of the Insta Lives that I've done, we've never had this issue. And so it's a real testament to the fact that, you know, when you think you're really in control, it's clear that you're not in control, and that there's someone else running the world, as we all know. And we talk about this a lot on this page and in many pieces of our lives. So usually by this point, I've been talking to you for about a minute. Usually the guest is already on here, and I'm able to bring him on, and for some reason I'm not seeing him. Oh wait, actually he just joined. Baruch Hashem. Okay, Dr. Werner, I see you, and I think it'll be another few seconds and we are going to start. Thank God. Baruch Hashem.
So sorry about that.
Here we are.
I take full responsibility. It's the close to 60 problem.
Okay, it is all good. It is all good. We are. This is as I was just telling all of the viewers. I said this is extremely humbling for me, because as much as we all try to plan, we plan and God laughs. So here we are. But time 4 was the charm. So here
to your credit, you did try to do this 2 days ago, and then 15 minutes before, so I take the responsibility.
It's all good. It's all good. There's no one at fault here. We needed to have a delay for some unknown reason, so we're delayed. It's all good. Okay, Dr. Werner, please, you have an incredible, illustrious background and bio. I'd love for you. I did give my viewers a little bit of your bio and your background, but as one of the foremost researchers and clinicians in male infertility, I'd love for you to introduce yourself in your own words, and really just, after we do that, I'd love to just launch right into our topic. So please introduce yourselves to the audience.
Great. So
yourself.
Michael, I'm a urologist. And I have 4 sons, and I was trained, if you want, at Harvard, then UCSF, then did a full residency in urology, and then did a fellowship in male infertility and male sexual dysfunction. So our practice is located, we have an office in Westchester, in Purchase, New York, and then one in the city right next to Grand Central. Mays actually was just named by my wife, who was in marketing, after Matthew, Adam, Zach, and Evan, so our 4 sons. So it was sort of a fun name that we just sort of came up with.
Wow, that's amazing. I had absolutely no idea that was the origin of the name. So phenomenal.
People have seen me for years and had no idea, but I thought I would just put it right out front. It's sort of the right group. And that's the story. But the practice
Dr. Werner, keep talking for just Michael, keep talking for just 1 second. I just want to, there's a window open here that there's a little bit of ambient noise. I just want to shut it. So just give me a second, keep going, and I will be, go ahead.
So the practice is located in those places, and we only do male infertility and male and female sexual dysfunction. So we have a lab that does semen analyses. We also have sort of the the local, when I say local, probably one of the biggest sperm banks in Manhattan. And again, with the sperm bank, we're banking men who are going to be using it for their own partners or for a designated person, not an anonymous bank. And we also have a cord blood bank. I'm a great believer in cord blood banking, and we do it very well and about half the price of the big banks. And that's our story.
Amazing. Amazing. Okay, so let's launch into this. I mean, this is a very large topic that clearly we're not going to cover the entirety of it in 40 minutes, which is really what I try to keep these Insta Lives to. But male infertility, I mean, we know, again, you're the expert, I'm not, but we know that the male aspect of infertility, the piece that's sort of designated or has been found to be sort of a male issue, is somewhere around the 40% mark, if I'm not mistaken. Is that correct?
Yeah, so the best way, the numbers break down the most easily by about 40% of the time it's mostly a male factor, and 40% of the time it's mostly a female factor, and then 20% it's a combination. So really 40% mostly male, 50% where a male is an issue. And about 15% of couples have primary infertility. So that's a significant number of men.
Significant. And so when someone gets to you, I mean, obviously they're going first to their reproductive endocrinologist, or I guess I should say first to their OBGYN if they're having issues getting pregnant. And then eventually they end up at a reproductive endocrinologist who then does a sperm analysis and determines that there's an issue, and then they get to you? Like, how does one get to you?
So again, I've been practicing, it's almost 26 years. So it's always the age of my youngest son. And it used to be, like in the old days, all of the patients came from the reproductive endocrinologist. All of your audience know who reproductive endocrinologists are,
Yes.
right? Okay. So, and by the time they came, the woman had had her complete evaluation, right? So histosalpingogram, ultrasounds, maybe even a trial of Clomid, believe it or not, because the last thing the man wanted to do was come and do a semen analysis. We are getting better in terms of the sexism of infertility. And so it's interesting, a lot of men, when I opened my practice, there was no internet, and there was no Viagra, for example, by the way. And so a lot of people really only could come through their physicians. But now actually a lot of men, a lot of couples say, okay, we're thinking of trying and we want to see if we have a sperm count. So the men will send themselves. It's really amazing. It's actually very nice. And it's actually you want to do it concurrently, because if you think about a woman's evaluation, it can take several months. The man is, it's a one test, obviously sometimes we repeat it to establish a baseline, but it's a very easy place to start, and so I always encourage people to sort of do their evaluations and treatments concurrently, because let's say that we find something and we can fix it in the man. Spermatogenesis, from the time the sperm divide until a man ejaculates it, is 3 months. So the lead time is 4 to 6 months. So it's nice to not to get
and I think that that's a real testament to sort of the knowledge base that the public has now in general about infertility, that before in ages of old, as you said, and not to say that you were old, but the fact that 26 years ago you started your practice, but that
I am old.
Okay, but I didn't say. But
I can say, yeah.
when you started your practice, and we as a community and also we as a general American public, we're not talking about infertility, and if we were, oh, this was a woman's problem. The fact that you're getting couples independently coming to you or concurrently, when they're being evaluated on the female side, I think is phenomenal.
Yeah, no, it's a different generation. And look, no one likes to be, no one wants to be infertile, by definition, and it is a big hit both for people's egos, men and women, when they have issues with fertility. I think that we baby men often more in our society than we baby the women, and so a lot of the a lot of the women really feel badly that it turns out to be their partner's fault as opposed to theirs. You know, it's fascinating.
Yes.
Whereas, you know, the men seem to be more at peace with it if it's their
Right.
wives.
Look, there are, as you know, there's no stereotypical man or stereotypical woman. I mean, everybody obviously has their own feelings about these things, but certainly you're 100% right. And I think also the other piece that plays in specifically to this community, the Jewish community, and also the Jewish religious community, is the fact that, you know, there is sort of this notion or this law about not spilling men's seed. And so often what happens in some of the more, you know, religiously right communities is that when a couple is trying to get pregnant and they can't, so they're told on high from their rabbis, oh, make sure the female gets tested first, figure all that out, and then if that doesn't bear out its fruit and there are no issues there, then maybe we'll allow you to have the sperm to be tested. So and to me, you know, look, I'm in the modern Orthodox community, so those communities are not, you know, where I'm personally from, but it always seemed, those comments and those notions always seemed counterintuitive to me, because the entire purpose of this exercise is to create a family and to specifically not spill seed. But obviously I understand where that is coming from. So it's just sort of an extra added layer here.
Right. The interesting thing, of course, about the Haredi community, which I work very closely with, is first of all, they can be unbelievably sophisticated about infertility. They're the ones actually who brought to my attention that extended sperm search, which we'll talk about later. And of course, and also the other advantage is that usually the women are, you know, somewhere between 19 and 24 when they discover this. So the clock is not ticking the same way it is, you know, with the average. Also in the modern Orthodox community, it's a younger age on average than it is in the secular community, you know.
Right. Absolutely. Okay. So let's sort of really get into it. What are, you know, when a couple comes to you and it's determined that there is an issue with the semen, what are the common causes, first of all?
Right. So there's a difference between having low numbers and zero, but some of the causes can be the same. So the most common potentially reversible causes are hormonal issues and what's called a varicocele, which are dilated veins in the scrotum. So again, these are men who have sperm but suboptimal numbers. Stepping back for a second, it's an exercise that I've found very useful, sort of a paradigm. The way I look at infertility when the couples are in front of me is I always tell them, let's say that it takes 100 points to have a baby, okay? Some points come from the woman and some points come from the man. Obviously, no one has 100 points because we can't self-reproduce. But there are women who are super, 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 super fertile, and their husbands get, you know, they get pregnant with terrible semen analyses on their husband's fault, on their part. And then we have vice versa. Some women who really you would never expect are going to get pregnant, right? How many stories do we know of women who've come back from their doctors who have said, you will never get pregnant, and they do? And that could be, you know, a combination, obviously, of luck and whatever, but also they may have a very super fertile, you know, partner. So that's sort of the thing. So if we feel like the couple is subfertile, by definition, not getting pregnant within a year, or if a woman's over 35, we use 6 months, then our assumption is that they don't easily have those points as a couple. And my job, or our job as a team, an infertility team, is to get them extra points. And there's 3 ways of getting extra points. 1 is to see what's going on with the woman, and if possible, to fix that. 2, to see what's going on with the man, and if possible, fix that. If we can find something that's reversible and permanent, those are the best points to get, obviously, because let's say a woman has blocked tubes. If we unblock them, it's not a great example, but then in theory, then for every cycle, you get those extra points. If a man has a suboptimal semen analysis and I can reverse that in a permanent way, then for every month they try to conceive, and for every subsequent baby they try to conceive, those points are there. So those are always the best points to get. And so that's
I love the way you couch that with the points. I think that's brilliant.
So,
and so what happens? So you're talking about if the man has points and the woman has points, and then you try to build up the points themselves. So, but what are you specifically doing? So we're going back to the specific.
Right. So going back to what I can do for the men, which is sort of, yeah. So for the men, the most common things that we find, again, there's a lot of them, but assuming again that they have some sperm, but I'll say that it's suboptimal, then in those cases, what the most common thing is a varicocele, which are dilated veins in the scrotum. So people have seen people with varicose veins in their legs. The most common group that have those are actually women who've had a lot of children. But men can also have that in the scrotum. And we know that that has a negative effect on the sperm production, both actively damaging the testis over time and suppressing the sperm production, not only in the one testis if it's only on one side, but in the other one as well.
And the other one as well. I didn't know that. That's very
so that's why classically everyone thinks I'm a genius because they'll say I have a varicocele. I say, oh, is it on the left side? And they'll look at me like, well, first of all, I could have flipped a coin, but second of all, it is true that about 95% of the time that's where it is. And if they have it on both sides, the larger one will be on the left. It's not worth going into why. We don't actually know why, but that's just a truism. And so basically the theory is that the extra blood is collecting there. The testis is not supposed to be at body temperature. That's why it hangs down, and men will notice if it's cold, it kind of comes up. If it's hot, it sort of goes down. One of the questions actually that I think we were asked about is a woman has a baby boy who had one testis that was, first of all, undescended and then I think subsequently removed. And will that affect his fertility? And the answer is no, actually, because if you have one undescended testis, there's a reason why they come in pairs, and it's very good at compensating. There's actually what'll happen is as he goes through there's something called compensatory hypertrophy, which means that one will get bigger to compensate for the absence of the other one. So the only thing I would suggest, of course, is that testes can be damaged and testes can get tumors. So it depends on how conservative you want to be. It may be worthwhile having him bank when he's 18, depending on how you look at it halakhically, just to have, a peace of mind. But again, the chances of, someone 18 damaging a testis is small. Someone's
asking, I'm sorry, I'm just going to interrupt. Someone's asking, if a varicocele in a male can be associated with an ectopic pregnancy in a female. I don't see how one is related, but maybe there's something I don't know.
So those are questions, and you'll see we have other questions there. We have one with premature ejaculation. In other words, so no. The answer, first of all, in other words, that's a very easy, hard no. So the answer is the varicocele is affecting the sperm quality, which is affecting their chances of getting pregnant, achieving a conception. If they achieve a conception, there's absolutely no evidence that it in any way affects the quality of the embryo and then baby or the pregnancy.
Right. So, or the placement of that pregnancy when the pregnancy is achieved.
Yeah, like Kalbachomer, certainly not that one. Yeah.
Correct. Okay. So varicoceles are one of the most common causes of male infertility.
Right. So I'll get back to this. So let me just finish with that one, and then so Fix-It is a very minor outpatient operation. So and then again, and you can get fairly dramatic improvement. And so there are definitely couples if he comes in with a large. My other 2 points. I'm always trying to balance two things when I'm seeing a couple. One is we're trying to get them pregnant as quickly as possible, right? But at the same time with the least amount of intervention as possible, right? We can take every 19-year-old who's had 3 months of infertility and do an IVF, and we'd have a lot of babies, but it would be overkill. And we could take 39-year-old women and say, come back in 2 years, you haven't tried hard enough, and we would be missing the boat. So we're always trying to balance those two things, So there are definitely couples where the guy comes in with a huge varicocele, terrible sperm count, and I'll say, finish the evaluation with the woman. If she has blocked tubes, it doesn't matter. Do that, but then let's fix the varicocele. Let's wait our 4 to 6 months and see what's happening. That's easy in a 24-year-old. It's not easy in a 39-year-old woman. You know,
Correct. I
that's
mean, that makes perfect sense. Obviously, everything is thought of in context, so that makes perfect sense.
right. Just as a humorous piece, I mean, I really cringe when the man comes in by himself without his wife, because they really, as a group, you know, I like women better than men, so I apologize in advance for all of my sexist comments, but the men like will know nothing. Like, I've had the men come in, they fill out the questionnaire, it's like, why are you coming in? Because my wife told me. Like, literally, that's the answer that's there. And they're calling their wives, you know, like, did you have an ultrasound? Did you have an HSG? Did you, you know, so it's like, so the women are 90% of the time running this show. The men are taking over more, but they are never taking over. Let's put it that way.
Well,
So,
I'll say just knowing the demographics of my account and knowing that over 95% of the people that follow me are female, I'm sure that there are many people who are chuckling at your comments just now. So besides me.
It's just true. So we really are looking at the couple, because, you know, it just depends on the context. You know, if a woman is 39, has blocked tubes, and the guy has a big varicocele and poor sperm count, well, she's going to need IVF. So why am I waiting to fix the varicocele when he has sperm?
Right.
You're going to go right to an IVF. Like, there's, so it's really, the context is key.
Right. Okay, so
Having said that, I'm sorry, I keep interrupting you.
No.
But it also drives me insane the other way, where reproductive endocrinologists will see that the man has a suboptimal semen analysis. It's a reasonably aged woman, and then just go right into IVF without trying to improve the quality of the man's sperm. You know?
Look, this is, I mean, this is a two-way street, right? Everybody has to, as you said, I loved your point system when you were describing it before. Like, if both of the points are suboptimal, obviously you want to try to raise both of them in order to achieve a healthy pregnancy. So yeah, that makes perfect sense.
Yeah.
Okay, so tell me, you know, so we talked about, you know, varicoceles as like being a huge, one of the most common causes of male.
And the other cause, right, so the other two, that's what are hormonal issues. So actually, one of the main things we see less in the modern Orthodox community than in the general public is that men who use, but sometimes unwittingly, men who use steroids, if they use anabolic steroids, basically testosterone, that will temporarily often shut down their sperm production. So
Okay.
we do see a group of those men, and then of course we have to take them off the testosterone and then give them drugs like Clomid, believe it or not, or HCG, wow, which then stimulate them to make more testosterone on their own, and then give them testosterone. But some men come in with they can come in with a pituitary tumor, and that's suppressing their sperm production. They can come in with serious thyroid issues. They can come in with a very low testosterone. So sometimes we can do hormonal manipulations that can make dramatic differences.
Amazing. And so if you were to characterize sort of the percentage of, you know, the causes, would you say it's what, 50%, 60%, generally speaking, are varicoceles, and a smaller number are more hormonal issues, or what are the numbers there?
It's a great question. And I would say it's sort of split between. The nicest thing, unless the hormones are significantly off, we do much better with the varicoceles than we do with, you know, subtle hormonal manipulation.
Okay. So let's now move. I mean, you have a couple who still eat, or couple, or I should just say a man. You have a man who, you know, doesn't have varicocele and also does not have any hormonal issues, and still their, you know, semen analysis is suboptimal. Now what?
Right. So my job is to maximize what I can, and then also to say, okay, we've done the best we can, and now we have to work around it. So again, going back to the point system, then what we have to do, the third way of getting points, you know, the first way is to maximize him, maximize her, and the third way is to get her more points in any given cycle. And again, the principles, as all of your followers know, are to get her to make more eggs in a given cycle,
right,
and to get the sperm closer to the eggs. So there's intrauterine inseminations and there's in vitro fertilization. So the key is, and that's a wonderful thing that we have, they were just starting to do ICSI when I started my practice, right? So yep, it used to be that if a man had a very, very poor sperm count, they weren't going to get pregnant even with IVF, because conventional IVF, you were basically just taking the sperm, putting them in the dish with the eggs, and if they didn't have a million moving sperm, they were not going to fertilize those eggs. And of course, where you can inject an individual sperm into an egg.
Right, ICSI. So I don't know if everyone knows what ICSI is. So ICSI is intracytoplasmic
sperm injection or insertion.
Sperm injection. I knew it was something with, so it has to be a sperm with an S in there. It's when the embryologists actually take the individual sperm and make a little hole into the egg, when obviously both of these things are harvested for IVF, and they actually insert the sperm into the egg in order to hopefully create an embryo, as opposed to just allowing them to swim together in this petri dish.
Correct. And you only need, so that you can have one sperm, even if it's not moving, if it's alive, and that can create a baby. So that's opened up the field dramatically for men, especially the ones who present with very low numbers of sperm or with no sperm, you know, in a regular semen analysis.
Right. So what is actually the definition of azospermia? Like, what does that actually mean?
Right. So azo means basically no animals or whatever, you know, so it means, so basically if a man is diagnosed as azospermic, it basically means his semen analysis shows no sperm, a conventional semen analysis. And usually you have to do it a couple of times. There's something called cryptospermia, crypt meaning hidden, like a crypt under, where they have very, very, very few sperm. So it used to be, if someone came in before we had ICSI, and they had azospermia or cryptospermia, and we tried to make things better, and we couldn't unblock him or whatever, they were done, right? Because finding one sperm wasn't helpful.
Right.
Now we can look for, once we do our evaluation, in many cases we can find a sperm, and then use that for ICSI. Take that one individual sperm, it has to be combined with an egg retrieval, and then they can, make an embryo and put it back into the uterus.
And so I mean, so obviously ICSI was the first thing that really revolutionized this entire field, but there are these other different techniques which you, along with A-Time and a number of other different folks in the field, have also developed, like Sperm Mapping and the ESSM. So I wanted you to talk about that, because I have a number of people who've been asking me, like, so what happens when I have this diagnosis of azospermia? Like, or what does that mean? And does that mean game over? And it seems like the answer is no at this point, that there's still potentially more that can be investigated.
Correct. So when a semen analysis shows azospermia, that can be from two main groups of causes. So one, it can be that they're not making any or many sperm, or two, they can be making them, but they're not getting out, right? So, so the not making them and, making them but not getting them out is its own evaluation. There are some men who are born with actually missing the ducts completely. That's my favorite diagnosis. The man walks in, he has no sperm in the ejaculate, and I can literally do an exam and say, okay, I can give you a 99% certainty that you're making sperm, that they're of a good quality, and you can do an IVF. I can go in and get the sperm, and you're going to have you have a very good chance of it. I love that, especially, I mean, not to be egotistical, but if it's been misdiagnosed somewhere else, it makes it even more fun. But anyway,
but and also when you're giving back hope to people who've previously thought they had absolutely no hope. I mean, that's the best feeling in the world.
Yeah, that's my favorite 5 minutes in my practice. So I walk in.
And you can do that on a clinical exam?
Yeah, because I'm examining the scrotum and they don't have any tubes.
Amazing.
So, that's really fun. In fact, actually at this point, before, that's why my wife says I have no social graces. I introduce myself. I say, have you ever been pregnant? Have you ever miscarried? Have you ever had any terminations? How often do you have sex? And let's go in the room and let me feel your testes. So it's like, so I'm not a chit chat person, as you may imagine.
Look, you know what? This is, you'd only get away with this in certain corners of the world. And you have that corner right now. So it's all good.
I do, but I sort of stretch it to most of my corners. Anyway, so,
another topic.
Yeah. So we're trying to see whether they're, if they're making them, but they can't get them out. So it could be that they're missing the tubes. It could be that they have ejaculation problems. It can be that so there's a bunch of different reasons why they could be making them. And sometimes you can just reverse that or find them and then harvest them. So that's its own bailiwick.
And is that what's called sperm mapping?
No, so that diagnosis is called obstructive, meaning blocked, azospermia. Okay? So you're making it, but you can't get it out.
Right.
So right now we're just doing what the categories are, and then we'll go into the procedures to diagnose. Okay,
sorry, go ahead.
No problem. And then so the next basket is that they're having a problem making them. So that has a bad name, which is the opposite of obstructive azospermia, called non-obstructive azospermia. So, but think of it as what I basically say: delivery problems, production problems.
Yep.
It's too complicated otherwise. Yep. So now you have a production problem. So that's where those techniques that you were talking about come in. So my first thing to do is to see if there's any way that I can make them make sperm. Like, do they have a big varicocele? Well, then I can and make sperm in the ejaculate. So I do the same things. I'm looking for the reversible causes. As an aside, I'm doing genetic testing also because there are a couple of genetic diagnoses, or one in particular. If they're missing all of the genes that you would need to make sperm, then you're not going to be able to make sperm. And no matter what I do, I'm never going to find them. You know, so
and that's Klinefelter's, correct?
No, that's called
not Klinefelter's.
That's not Klinefelter's. That's called Y microdeletions.
Okay.
So on the Y chromosome, they're missing the genes that code for sperm production.
Interesting. Okay.
So Klinefelter's is another genetic test that we do. It's called a karyotype, looking to see if you have the right number of chromosomes and if the big pieces are in the right places. So that's called a karyotype. Klinefelter's is one of the most common causes of production problems, and that's where the man has an extra X. So he can look very much like a guy. He has a penis and testes. The testes are almost always very small. The man is sometimes very tall, like sort of. And but the interesting thing is that some of those men actually, especially when they're younger, will have sperm in the ejaculate. And ironically, as they get older, it gets worse. So I happen to work with one of the premier Klinefelter's clinics in the world, and they've been sending me their patients now. So I've developed that especially. But they are an example of a production problem.
Production problem. Okay, got it.
Okay. So just, do you have a question? You wanted to?
No, I'm trying. So I'm trying to, as we're talking, trying to weave in all the different questions that are both popping up now and that I've gotten
anytime.
So we have production problem or we have delivery issue. So delivery, we can unobstruct them, and so therefore hopefully everything becomes okay.
Or harvest the sperm, whatever.
Or
we can get sperm. We know we can get sperm. Yeah.
Okay. Production problem.
Right. Now, so first I'm trying to do is see if I can make it better. So can I make them produce more? And that's the varicoceles and the hormones. Then let's say that we can't. Then our next step, and that's, I think, the most interesting thing and the most revolutionary thing that we have been doing. So these are, is what's called the extended sperm search and microfreeze. And this is a technology that, not surprisingly, was developed in Israel. And that we were introduced by a fertility group that services the Haredi called A Time. And
A Time, just as a quick plug for them for 5 seconds, A Time is a phenomenal organization that helps, I would say, thousands, if not tens of thousands, maybe hundreds of thousands of families all across the world with infertility, also with pregnancy loss. And they were the ones, and now this is your story, so I'll let you continue on with them. And I work very closely with them on many different clients, but keep going.
Yeah. So basically, Rabbi Koenig, who does their science, is one of the guys, or the main guy who does the science, said we've actually been sending our patients to Israel to do this, and we want to develop a lab here. And after a couple of false starts, we created the lab, and they're one of our main clients, and they've been giving us advice as we go through. But so the principle is that if men make very low numbers of sperm, they're not going to show up in a regular semen analysis. In other words, if you have a 10 cc, if you take a 10 cc's or a gallon of something and you put a little grain of sand in it, you're not going to find it if you just take a drop and look under the microscope. But if you process it correctly, actually, this is a good analogy, I haven't used it before, you'd be able to find that grain of sand, or if there's 20 grains of sand, you should be able to find them if you process it correctly. So what we do is we spin it down in a specialized way, and then actually over 6 or 8 hours, so we take little drop, all of it, all of the specimen, it goes in little droplets, and then our technician, who is also a religious lady, and she will go through and look through each drop, and if she finds one, take the micro manipulator and put it onto a drop, and then when we're done, we put it on this little microchamber that the Israelis also found, and we flash freeze it, and what that means is that most of them survive the thaw, like 90%, and it's very easy for the IVF center to find them because it's in this little teeny amount of fluid. So we've converted over, and 40% of the men, actually a little bit, of the men who have the diagnosis of azospermia, we're finding sperm on. So it's very exciting.
I mean, that's an absolutely unbelievable number. Unbelievable number that almost half of the people who are coming to you who've been previously told that they are that they have no possible chances, then all of a sudden have just completely revolutionized. I mean, their entire experience has changed.
Yeah, no, it's really exciting. And the nice thing about that is, if we didn't find that before we had that, then the next step was either to do what's called the sperm mapping, or which we don't have to spend time on, or what's called the testicular sperm extraction, where you go in it's an invasive procedure. You're looking through all of the tissue. You see if you can find tubules that have sperm. That's combined with an IVF. If the couple's not willing to use a donor, which most certainly ultra-religious couples are not, then you've wasted the IVF. Those eggs are just sitting there. So it really, if you can find them, it's remarkable. It's very exciting, and it's much less.
So it's basically a two-step process, is what you're saying. That someone will come to you with the delivery issue, and so you will go through the ESSM, and then if that fails, then you'll go through this more invasive process to look through the tubules. Is that sort of
correct?
The one step, two step?
Yeah, there is the one in the middle, which there's 2 people in the country who do it, which is called sperm mapping. So where what you can do, it's a diagnostic test, because what you do is, it sounds terrible, but it's actually much less invasive than the sperm retrieval. You actually map, you put a bunch of needles into the testis. The guys actually sleep through the whole thing. It's interesting, even without anesthesia. And then you actually, so you're looking at about 36 different specimens, and you send, each one's on a different slide, and we send them to a specialized lab. They look at each slide and tell us whether there's any sperm there, and if there is, then we know where to go back in. And if there's not, then the chances of the more invasive test being successful are very low.
So, I mean, is there an overall number that, if you're getting about 40% of the people who end up with some sort of sperm after the ESSM, what then, and then you get another 10% of people with the mapping and the tubule investigation? I mean, what at the end of the day, what's the percentage of the people who walked in and thought nothing, and then walked out and said, oh, we may actually have a shot here?
It's a very excellent question without a clear answer, because it's very operator dependent, and it's very dependent on which procedures people are willing to go through. But if a man gets a diagnosis of azospermia, I think it's very conservatively, it's safe to say that about 40% of the time we'll find sperm.
Amazing.
Yeah, so it's cool.
Amazing. Okay, let me get to a couple of other questions here, just as sort of a little sidebar. Someone asked previously, that her husband was diagnosed with obstructive azospermia, but then he ended up with testicular cancer and needed to have an orchiectomy to remove the tumor. The other testicle seems to be fine and healthy. But are there any, what she's asking is, are there any vitamins that he can take, or things that he can do to boost his sperm, to increase his healthy sperm? Right? Not only him, just in general. What are your recommendations?
It's a very interesting question. I wouldn't tell people in general to be on any, I mean, the healthier you are, the healthier your sperm, you know, within reason, though we have very unhealthy people who have great babies, etc. And
yep.
it's not a fair correlation. I think one of the reasons I've always been passionate about fertility is, first of all, I think there's nothing more important. I'm obsessed with people having babies. But secondly, it's just not fair, right? You have people who don't want to have babies and get pregnant, and you people are dying to have babies. So it's a very unfair distribution.
Yes.
Welcome in general, yeah. So I think there are some people feel like if there's a lot of white blood cells, they should be on antioxidants. If it were me and I was her, I would if it's an obstructive azospermia, then I would probably get those sperm and put them in the bank, you know, depending on what the cause is. And then because the younger you are, within reason, you know, when you harvest the sperm, the higher quality the babies are, just as they are with, you know, and on average, you know.
Right.
So we know that, you know, we used to think this is only a female issue, you know, with more genetic abnormalities in the children of women who are older when they conceive, but we're seeing that men. Obviously, we don't have menopause, meaning that it's like, in theory, it's a very slow and much later, you know, complete cessation of the ability, but it's definitely there. And also they're seeing more schizophrenia and autism, you know, in the babies of men who conceive, you know, after 40. So, I mean, I do think it's so easy and inexpensive to sperm bank. You know, if you're reaching your late 30s and you are not in a relationship or not anticipating, I would bank sperm. I mean, I would much rather use the sperm frozen from a 35-year-old than from the fresh sperm of a 45-year-old, personally.
Right. I mean, That's, I mean, it's the same argument for why, you know, females are doing, you know, egg freezing. It's exactly the same thing.
Right.
Okay. Switching gears. A number of people have been asking about mumps and what if an individual is known to have mumps as a child or mumps at any point in their life, what is the effect on their sperm count? What does it mean for them?
Well, first of all, really, almost no one should be getting mumps now. So that's very rare. But when I did have the mumps, but the things about the mumps is if you get it after adolescence, if you get it before adolescence, it's almost irrelevant. If you get it after you've gone through puberty, then you can have what's called a Mumps Orchitis, meaning that virus can cause an inflammation and then subsequent damage to the testes. So there are men who've become sterile or had azospermia from actual mumps, but it's usually but they would know it usually, or they, you know, because it's usually after they would know it, because they would have very sore and swollen testes when they had the mumps.
Okay, and does it permanently affect their sperm count, quality, etc.?
Yes.
Or and it does.
Yeah, what it's doing is when you have the Mumps Orchitis, it can permanently damage the testes.
Okay.
So get your vaccinations.
Okay. I mean, yes. Without question.
Yes.
Without question. Okay, let me get to, 1 second. Let me get to another one over here. Tell me about, someone's asking, like, so what happens if your answers are, you know, no, 0? Then what? Like, you can't find any sperm. I mean, are your only options donor sperm? Are there any you know, anything coming up the pipelines in terms of stem cell transplants? Like, is there anything else out there yet, or is it really just your only answer is donor sperm?
Yeah, practically that's your answer. You know, I've been, you know, we keep getting more and more sophisticated about stem cells and things like that. In fact, we have a cord blood bank, but I haven't seen it happen.
Okay.
So, you know, again, it depends on, you know, your halakhic, you know, it depends on your halakhic orientation.
Correct.
As a regular practitioner, I love donor sperm. I love donor egg. You know, I think people who want to be parents want to be parents, you know, and for most people, if who really want to be parents, if someone handed you a perfectly healthy great baby in your lap, you would say, that's great. And you would take care of them, you know, and be very happy as a parent. So, you know, I find actually, you know, all the studies show, again, I can't fight with halacha, but all the studies show that in terms of being well-adjusted and happy children, they are just the same. The key, though, which is fascinating, is that not if they're not told. If it's a secret, it becomes a nightmare, and those children do poorly as a group. But if they know from the very beginning, it's almost like, it's like not telling an adopted child that they're adopted. Right. No one would conceive of doing that now, that they used to try that. And now it's the same, you know. And
fascinating.
Yeah, because families with secrets are families with problems. You don't want
look that we know, right? That's a general issue. That
yeah,
exactly. What I will say is that I mean, this is, you know, in terms of this community and the people who follow me, there are lots of different people who have different halachic opinions on this. And what I always say to everyone is, make sure that when you're asking your questions, when you're asking your shilas, your specific fertility shilas, please make sure that you're going to someone who is the real expert in this area. This is not about you going to your local rabbi who really doesn't know anything about infertility or doesn't specifically understand male infertility or the different nuances in this testing. Please make sure that you find the expert who knows exactly what all of these tests are, what the different ramifications are, what the possibilities are, and who understands how to merge Jewish law with all of these modern procedures and what is allowed and what is not allowed within your framework. That's what I always say. Like, you wouldn't go to a pediatrician if you had a heart problem. You would go to a cardiologist. So in the same way here as well, you want to go to the expert. You don't want to go to the local person. So I always say that to this community, and I just want to remind people again about that. And if anyone has any issues or wants help trying to find an expert in their field, you know, they can reach out to me and I can put them in touch with people who are connected in different communities, and we can help get you to the right person. Okay, there's one other question down here, and then I think we're going to end in another minute or two. Someone's asking, what % of this population really have no sperm?
Right. So again, I would say it really depends on if you've been evaluated by someone who's really an expert and we've tried to maximize you, and then we have tried to do the extended sperm search and or the sperm mapping and or the testes, it's still about 50%, you know, 40 to 50% are just really not going to have sperm. Okay. So it's not insignificant. It's just that when people walk in, they think there's a 0 chance, and we're giving them, you know, but there are definitely men that I'm not right. But there's men that I'm going to turn to and say, we're done here. You have to decide what you're going to do.
I mean, look, the fact that you are able to do this and the fact that these tests are offered here in the United States and people don't have to travel overseas for them is tremendous.
Yeah, it's been fascinating. The extended sperm search, we're getting people from all over the world coming to us now.
Really? Okay, yeah. Amazing.
Yeah.
Dr. Werner, if people want to reach out to you, and I'm sure that there are going to be many people wanting to reach out to you because there are a number of questions that popped up here that were a little bit too personal that I didn't want to specifically mention here. And I think people really should reach out to you specifically, and or if they want to make appointments. What's the best way to reach you? It's through you're now on your personal account, but when I put up your link, it's going to be through Maze Men's Health, and that's the place that you want people to reach you, correct?
So yeah, no, I'm a big Instagrammer. Sorry, I missed that, but I had an alarm going off.
Yep.
So I apologize.
Oh, good.
So yeah, I think that the office is the best way to reach me. The easiest number is the 91. Well, Maze Men's Health is really easy to find. MAZE, Matthew, Adam, Zach, and Evan, and Men's Health. And the easiest phone number is the lab's number, which is the 914-683-0000. I was very excited that day that we got that number. I know, it was really cool. And so, but that was a long time ago. But it's very easy, obviously, to find anyone on the web right now. Yeah.
Okay, phenomenal. So the pointed question that someone asked is, are you open to calls and consultations? And the answer obviously is yes.
Yeah, I'm a practicing physician.
Yes, absolutely. This is what you do. This is what you do.
This is what I
Okay,
do.
phenomenal. Dr. Werner, thank you so much. This has been incredibly enlightening, helpful, and I know, the questions have been pouring in. There were questions beforehand. I know, as we know, 40% of the time, there's definitely a malfactor, and so 40% of the people who are out there are concerned and have questions, and you have given hope to so many people just through this conversation, but also clearly in the work that you've been doing over the course of your career. So for all of them, I'm thanking you so much for your work and for being here.
My pleasure. This was fun. Sorry for the snafu at the beginning,
All good.
which I take responsibility.
All
And we'll do this again if you'd like.
That sounds good. If anybody has other topics that they'd like us to discuss, we are open to them.
We could talk also about male sexual dysfunction and how that relates to infertility. That's always.
You know what? I think that would be amazing. I'm writing it down right now, and you and I will make a date, and we'll do this again.
Very good. Everyone stay safe and healthy.
Amen. Thank you so much. And to you too. Thank you.
Take care. Bye-bye.
Okay. Take care. Bye-bye.